Okay, well, I would like to welcome Dr. Orly Weiser-Pike. She's an associate professor in the Department of Occupational Therapy. She earned her bachelor's of science in occupational therapy from the University of Cape Town, South Africa, and her doctorate in occupational therapy from Chatham University. She joined UTHSC in 2008, and first as an assistant director of the Low Vision Service at Hamilton Eye Institute in the Department of Ophthalmology. She then joined the Department of Occupational Therapy as a full-time faculty member in 2017. She's taken a particular interest in the role of occupational therapy with children who have brain-based visual impairments, commonly known as cortical or cerebral visual impairment, which plays nicely with her previous experience. And her current research interests include examining the validity and reliability of assessments of CVI that can be utilized by occupational therapists. She's going to talk to us today about how to recommend an outcome measure, a journey through a systematic review of occupational therapy assessments for cortical cerebral visual impairment. So I'd like to welcome you, Orly, and thank you so much for presenting to us today.
Thank you so much for that kind introduction. Thank you everyone for being here. As I said, my name, as Dr. Carson said, my name is Orly. I have a lot of kind of an alphabet soup behind my name, so I just wanted to share with you what that is. It's a doctorate in occupational therapy, and I'm registered and licensed as a clinician in the state of Tennessee. I'm a certified low vision therapist, so I've had that certification. I've been in the field of low vision for over 2 decades. I received certification as a low vision therapist in 2004, and I received specialty certification in low vision, that's the SCLV, from the American Occupational Therapy Association. That was a certification that was available from 2006 through this past year, through 2023. And I was recognized as a fellow of the American Occupational Therapy Association in 2017, I think. But I've been in the field of low vision and vision impairment really since the beginning of my career. I was interested in how vision impacts a person's ability to do their daily occupation. So I just wanted to kind of go over a little bit what is cortical vision impairment or cerebral vision impairment. There's a debate between European healthcare providers and American healthcare providers about whether it's cortical or cerebral. And so I'm just going to say CVI. I'm not part of that debate. But basically what it says is that it's a vision impairment that cannot be explained by a problem with the eyes. So in my 2-decade career in the field of low vision, a lot of the focus was on what was going on within the eyeball, what kind of disease process was happening within the eyeball that was causing vision impairment. But CVI is different. It's caused by damage to parts of the brain that process vision. And the processing of vision isn't just in the occipital cortex as we kind of traditionally learn about it. It's all over the brain. There are connections between the eyeballs and just about every part of the brain. And so when there's damage to the brain, either before birth, like from a genetic condition, or during the birth process, any kind of anything, inflammation or a metabolic condition, anything that can cause damage to the brain is likely to result in vision impairment. CVI is now thought to be the leading cause of vision impairment in children across the globe, so in developing countries as well as developed countries. And because it's so diffuse across the brain, the processing of vision, there's so many different kinds of visual processes happening. There are also so many different types or different expressions of CVI. So I kind of wanted to give you a brief simulation of what it might be like to have one kind of CVI. So if you can look at the pictures over here on the slide and see if you can find rhyming words for 3 of the objects that you see. And I'll just count to 10 in my head and let you do that. Okay, so you don't have to answer. We'll just move on. But those images were created by artificial intelligence. There's really nothing that we could, there's no real objects in those pictures, but it kind of gives us a little bit of insight of what it might be like to not be able to visually process images or understand what we're seeing. Because the process of vision is more than just seeing, it's also interpreting and understanding and then interacting with our world. So just like with ocular impairments that can have a range of visual dysfunction from mild to moderate low vision all the way through blindness, with CVI, there's also a wide range of different expressions. In children, the impact of cortical vision impairment may lead to difficulties playing, for example, matching puzzle shapes, learning to read and write in preschool and then in elementary school, all the way through. It can impact mobility, so finding the way to the cafeteria or to the restroom. Difficulty making eye contact is a big feature of cortical vision impairment, and this can really impact the relationship and bonding on behalf of the parent who may not understand that this is a visual processing issue. Recognizing friends on the playground might be difficult, leading to difficulties with social interactions. And there's not any research into this, but from my clinical experience, it seems like hand development could also be impacted because there's a difficulty in reaching accurately for objects. Children often appear to swipe at objects, or they may appear to be uncoordinated in interacting with objects. So there's a lot of things that can, there's a big impact on daily occupations, and a lot of things that we don't know and still need more research. And then the other thing about CVI is that vision can fluctuate according to the time of day, according to the conditions, the environmental conditions, if it's crowded, etc. So it's a very complex issue that requires a lot of accurate assessment and interventions. And I have been seeing a lot more children being referred to the clinic for cortical vision impairment. So I became interested in CVI, especially around 2017. I had an ophthalmologist, one of the ophthalmologists in the clinic at Hamilton Eye Institute, where I have clinic, was referring more and more children, and I wanted to learn more about this. And so I was seeing children, but I didn't really know what assessments would be relevant, especially from within my profession. In my profession, the specialty certification that I received was really only geared towards adults with age-related vision impairments. So there was not a lot in my professional literature about how to assess and treat children with cortical vision impairment. I also wanted to know if the assessments that were available, were they accurate, were they trustworthy? And I also wanted to know what they would be like in the clinic, were they user-friendly? So I do want to mention Dr. Anita Mitchell, who I was very lucky when I joined faculty in 2017 as full-time in the Department of Occupational Therapy. She was assigned to be my mentor. And I'm very thankful for her because she was a collaborator in the systematic review that I'm going to tell you about. And I am not trained as a researcher. I'm a clinician. For most of my life. My doctorate was a clinical doctorate, and so I really had very little training about how to conduct any kind of research. And Dr. Mitchell helped guide me through this project. She was my main collaborator. Another collaborator was Leah Cordova, who was a librarian in our health sciences library. But most of the work was guided by Dr. Mitchell. So these were our research questions. What is the evidence for the measurement properties of currently available instruments that measure or diagnosed CVI, and which of them were applicable to occupational therapy practice, and then what was the clinical utility. So just like those questions that I asked earlier, what was it like to use these instruments in the clinic? So this is an overview of the systematic review. Initially, it was going to be a scoping review. And there's I met with health sciences librarian Leah, and we discussed the differences between a scoping review and a systematic review. And there was some literature out about the different assessments that were available, but they hadn't been evaluated for the quality of the evidence. And so it appeared that, the more we discussed it and the more we looked into it, we needed to do a systematic review. So I'm going to tell you the different parts of this systematic review. But we started out with our search, and we wanted to know what were the currently available CVI instruments that were out there that were applicable to occupational therapy practice. So we did a search, and we used different, we had a search strategy. We looked at different databases with different search terms, and we had inclusion and exclusion criteria. I don't want to go into all of that, but the net result was that, before I get into the net result, I do want to tell you, we used the Ryan platform. So if any of you have ever are familiar with it, it's a great platform. It doesn't look like the screenshot because that was from yesterday, but it looked a little bit different. But what it did was it enabled each of us, each collaborator, each researcher, to independently review each result and decide whether we wanted to include it or exclude it, whether we wanted to, and we were able to tag it as well. And we were able to then arrive at a consensus. So we looked to see how much we agreed on. Where we didn't agree, we had discussions and decided whether we were going to include or exclude that source. But basically, after this very thorough search strategy, after we applied it, we ended up with 12 assessments that were relevant for occupational therapy. There were 15 articles, but they were reported on 12 assessment tools, and we divided them as performance-based or clinician-reported outcome measures. So those are ones where the child had to do something and then was rated based on their performance, or the clinician was the one that assigned the rating to the child. And then there were 8 that were patient reported. So it wasn't the child that was reporting, it was the parent that was reporting on behalf of the child. So these were questionnaires and surveys. Most of them were had a rating scale, and some were just binary yes, no. And so again, I'm not going to go into each of these. I am going to discuss a little bit more of them in a minute. But we found all of these, and of the 12 assessments that were found, 10 were available in the public domain. So the next thing we wanted to do was to see, what was the quality of the study for each of the reported measurement properties. So we wanted to make sure that the study that was done was adequate, because a lot of biases can be introduced or can be caused by inadequacies in the design of the study, in the conduct, in the analysis, in the reporting, or the interpretation of the results. So what we did then was to apply the Cosman risk of bias checklist. I'll go into that in a minute, but first I just want to mention measurement properties. So we were interested in the reported measurement properties. So the assessments that we found, we included in our systematic review only those that were within the scope of occupational therapy practice. So, for example, assessments that were about MRIs or doing visual acuity measurements or visual evoked potential or anything that wouldn't be with, something that we as occupational therapists are trained on, we excluded those. So, but the ones that were included needed to report on specific measurement properties. So what are measurement properties? Or what are the properties of good measurement? So we think of validity, reliability, and responsiveness. So validity is defined as the degree to which an instrument measures what it's intended to measure. And it includes different types of validity. Content validity refers to the extent to which this tool represents all the facets of the given construct. Then there's construct validity, which is about how well a test measures the concept that it was designed to evaluate. And there's criterion validity, which typically is assessed by comparing with a known gold standard test. Then reliability is the quality of being trustworthy or performing consistently and consistently well. And responsiveness of an instrument is the instrument's ability to detect change over time. So getting back to the Cosman, okay, so this was the first filter, if you will, or the next filter after we applied all the search criteria. Once we had our results, we looked at the Cosman risk of bias tool. And so this was used to assess the quality of the studies based on standards for design requirements and preferred statistical analysis. So Cosman is the consensus-based standards for the selection of health measurement instruments. So Cosman is just the acronym. And it's a group that's been around for also about 2 decades out of the Netherlands. And again, available in the public domain. Cosman has different tools depending on what kind of study that you're doing. The risk of bias checklist, again, it provides a methodology, specific recommendations for transparency of reporting and processing of evidence. So it's fairly simple. Well, it's not really very simple, but each measurement property, so there's 10 different boxes that you can go through for the different measurement properties. It has criteria for rating the study as either very good or adequate or doubtful or inadequate. And so a very specific criteria and instructions in a manual, and all of this is available again in the public domain. You can go to cosman.nl for Netherlands, I believe, and it's available to download. But this is just an example of, for example, if we were looking at content validity, there's a long list of questions that need to be rated to ensure that the study is, to rate the bias within the study. So when you're rating a study's methodological quality, according to the Cosman, the lowest rating of any item in a box is taken. So it's the worst score counts method, basically. So if everything is very good, but one of the items, one of these questions is rated as lower, say as doubtful, then the entire study is considered doubtful for this particular measurement property. So we did it. This is what we did for every single study. This is a table, and it's kind of just to give a big picture, zoomed out picture of what we found in terms of the risk of bias, we had a big spread. Each reported measurement property was filtered through the Cosman risk of bias checklist, and we plotted each rating on this table. And as you can see, there's a big range from very good studies that were very good to inadequate. And the study is for the specific measurement property that was being reported. So then next we wanted to know what the quality of evidence was for each measurement property. So we looked at risk of bias for the study using the Cosman tool. And then next we used the grade approach. So grade is the grades of recommendation, assessment, development, and evaluation. And that's another tool or a checklist, if you will. And the grade provides a specific definition for the quality of evidence in the context of making recommendations. And so just going back to the very beginning of this, the questions that I had was like, what assessment should I use? Like, who can recommend an assessment for CVI for an occupational therapist to use in a clinic? And how user-friendly is this assessment tool? So grade tells us, asks how confident are we in the results of the study? And there's a funny cartoon that I found in in a paper that was published about grade. And it says, the quote in this cartoon says, I figure there's a 40% chance of showers and a 10% chance we know what we're talking about. So making recommendations according to the grade, right? So again, there's very specific criteria. So in this phase, the results for each measurement property in each study are rated against the quality criteria. So they're called quality criteria for each measurement property. And the ratings are either sufficient, which is a plus sign, indeterminate, which is the question mark, or insufficient, which is the minus sign. And in this example over here, I just took a screenshot about to show you the quality criteria for structural validity, for example. So if an assessment reported the results of for structural validity, then in order to be sufficient, there needed to be a confirmatory for CTT. Okay, that's, again, I'm not a researcher, so it's classical test theory, but there needs to be a confirmatory factor analysis, and then a whole bunch of other criteria in order to, be sufficient quality of structural validity. And so it goes for each type of measurement property. So the grade approach considers that the initial quality of the evidence is high. Okay, so we start off with the assumption that the quality is high, but then it gets downgraded by one or more levels. So it can be downgraded to moderate or low or very low if there is serious or very serious or extremely serious concern. And there's different factors that are considered in terms of making the rating. So if there's risk of bias, okay, you can downgrade based on risk of bias, and we looked at that in the Cosman. If there's inconsistency of results, so if you have several studies and there's unexplained differences in the results of the studies, if there's indirectness of evidence, and we did find this, for example, if you have evidence from a different population than the targeted population. So for example, in one of the studies, the assessments, they had children with normal vision, but they put simulated goggles and blurred their vision. So that is an indirect result because you're not studying the real population. It's indirectly making inferences. So that is another reason to downgrade the quality of the evidence. And then imprecision, and that relates to small sample sizes. And we know that with a lot of these, in a lot of our studies, there were smaller sample sizes. So that can also downgrade the evidence. So again, here's the kind of a summary table, and I don't expect you to look at all of this, but this is a table that shows our results for each outcome measure. So this is a little bit different than the previous table that I showed you, which was each assessment tool. And so this is showing each specific outcome measure. So where content validity was as a measurement property, structural validity, internal consistency, etc. And overall, only one of the studies was insufficient, had a minus sign. The rest were either sufficient, so that would be a plus, or indeterminate, so that would be the question mark. But yeah, we had a big range of, low through or very low through high quality studies. Not a lot of high quality studies, and some of the high quality studies that we did have were actually indeterminate. So, okay, this again is just going, I'm not going to go through this, but we looked at every single assessment. So we have the name of the assessment on the left. We looked at what was measured, and then what was the quality of the evidence. So we went through this. This is kind of an expanded or blown out view of the small little colored table that I just showed you, but I'm not going to go over that. So then lastly, I was curious to know, okay, so how did these assessments perform in the clinic? I actually used many of them. So that was kind of the last filter for this whole systematic review, was to look at clinical utility. So I'm just going to give you some examples. Overall, there were 2 assessments that I found useful, and I still find useful, and I continue to use them to this day. One of them is a ClinROM, and one of them is a PROM. So one of them is a clinician-based outcome measure. So I kind of do an assessment and then rate the child. But there's another one that I wanted to show you, just to kind of tell you the difference between, or really to reinforce how important it is to try things out in a clinic situation, because sometimes the research that is reported, even if something looks really good in terms of its measurement properties, it's not always clinically feasible. And this is an example of, this is a screenshot of one of the assessments called the CVIT. So that's the Children's Visual Impairment Test. It's for children who are 3 to 6 years old, and it's freely available from the developers, who are also based, I believe, in Belgium or the Netherlands. They're based out of Europe. And it's a wonderful test. If you have typical vision, it is not easy. So there are 14 subtests, and each subtest has 5 items. So that's 70 items. But each of these subtests also has 2 practice items. So in fact, you have 98 items, and a child has to be looking at the computer screen and deciding, choosing the correct response. I've done this test with several children who are 3 to 6 years old, who fit the age range, and the researchers say that it's about a 20-minute test. It's much longer than that. It's very, very difficult for the children to sit for the entire duration of the test. So clinically, oh, and then another thing about this particular test is that there aren't any interpretation guidelines. So you get a result, but for there's no manual that or instructions on how to interpret the results. So it's a little bit problematic. Another thing that you might notice just in this picture is that the middle item says chocolate spread. Not sure that the chocolate spread is very common in Europe, not that common in the United States. I'm going to get to the chocolate spread in a minute. Here's another example of a PROM. So that's a patient-reported outcome measure or a parent-reported in this or caregiver reported in this situation, where a lot of them, most of the PROMs that we found, so there were 8 PROMs and 6 of them had a 5-point rating scale, had up to like around about 50 questions. Some of them vary, but this one in particular had 48 items, and it was a 5-point rating scale. So for each item, the parent had to respond either always, often, sometimes, rarely, or never. So you're asking the child, does your child have difficulty seeing scenery from a moving vehicle? And the parent has to respond either always, often, sometimes, rarely, or never. It's very difficult to get through a 50 or 48 question questionnaire and have that kind of rating scale. It's time consuming. Parents tend to go to either one extreme or the other. So personally, I've found as a clinician, it's easier when there's just yes, no type of questionnaires. That's my personal view as a clinician. All right, so what assessment is recommended? Okay, all of this was done in order to be able to recommend something, and the grade provides recommendations for how to recommend an assessment. Okay, so the grade tells us that there needs to be, at the very least, there needs to be sufficient content validity. So whatever's been reported about this assessment tool needs to report content on the content validity, and at least low quality and sufficient internal consistency. So internal consistency is a type of reliability. So there's sufficient validity and sufficient reliability. None of the assessments that we put through the systematic review reported on both sufficient content validity or sufficient internal consistency. None of them had both of those, so we couldn't actually make a recommendation. There was only one instrument that had insufficient measurement properties, and you don't want to recommend anything that doesn't have at least sufficient or indeterminate measurement properties. The insight inventory and structure, there were 2 that were unavailable, but that's not really important. Okay, so the bottom line was that we couldn't really recommend anything based on the scientific criteria and guidelines for recommending an outcome measure. So the next step, what comes next? So I told you from my experience using a questionnaire that is yes, no, is good. And then one that has been studied quite a bit is the Flemish CVI questionnaire. It's a 46-item yes, no questions. It didn't have the content validity and internal consistency. So it didn't have the reported measurement properties to be able to be recommended, but it has been studied a lot, and it does have some promising measurement properties. It's Flemish, so there are some things that are culturally not relevant to our culture. I mentioned chocolate spread. This has at least 3 items on it about chocolate spread. So it asks the child cannot take the chocolate spread from the breakfast table without difficulty, or the child looks away when the chocolate when he takes the chocolate spread from the table, or the child doesn't find the chocolate spread on the table. Well, I love chocolate spread, but I know that it's not a breakfast item in the United States. So I have got a team of collaborators that I'll introduce you to in a minute. And we're looking to, in first steps, doing a cross-cultural adaptation of the Flemish CDI questionnaire. So I've received permission from the author. So this was a questionnaire that's been studied since 2011. It was first published in 2011, and there's been at least 3 studies, different measurement properties of this tool, but we know it needs to be culturally adapted for the United States. I've received permission from the author to go ahead and do a cross-cultural adaptation, but that's going to involve a lot of steps. So first we need to do a linguistic translation, so translate it from the original Flemish into English. There's different kinds of translations. So forward translation is going from Flemish to English, and then a backward translation is going from English to Flemish. These are all scientific guidelines for cross-cultural adaptations that are presented here on this slide. So doing the linguistic translation, then cognitive debriefing, that means interviewing or making sure that the questions are understandable. Then we'll go ahead, hopefully once this is done, there might be items, well, the items will change. We know that we've got at least 3 items with chocolate spread that are going to have to change, but when you change an item, then you've changed all its measurement properties. So we're going to start off from ground zero and do a content validity study and study it, but that means that the items will have changed, so we'll need to request permission from the author to go ahead and study it further. If we get that permission, once we've completed the content validity, then we want to go ahead and look at other measurement properties, the internal consistency, so that we can recommend it as a tool and then pilot it across the United States in other, all across the United States. We're thinking of, once we get permission, once we complete all of this and get permission, then we can create an app. It's just a yes/no, very easy to score, very easy to respond to, and we can gather the data. And once we have that, we'll look at scoring and factor analysis. There's a lot more that we can do with it. It can be a long-range project. Well, just to end, I have some collaborators. Dr. Mitchell, who's now retired, she's going to continue to collaborate on this project. Dr. Bruce Kiesling in the middle, he's from the Department of Pediatrics in the College of Medicine. And Dr. Lauren Ditter, she's a pediatric neuroophthalmologist, who I mentioned earlier in my presentation. She and I have been colleagues for many years now at the Hamilton Eye Institute, where I have clinic and I see a lot of her patients, and she's also very interested in this. Well, thank you for your time. Here are my references, and I'll open it up to questions.
Thank you very much, Orly. Yes, the presentation is now open for questions.
Don't all speak at once.
Give them the 8-second rule.
So Orly, that's a very nice overview of the very systematic way that you went through the analysis. It was very, very structured, and thank you for that. I'm just wondering, in terms of Americanizing the policies, do you just simply change the chocolate spread to peanut butter, and then you've solved some of those cross-cultural problems?
We might think that that is accurate, but we have to, that's why it's so important to do content validity. And part of, one of the issues with content validity in a lot of these studies is that they asked experts. So the researchers asked the experts about the content, but didn't actually ask the parents or the patients. And so it would be important to do the content validity, and part of the design requirement that is required for a good study is that you ask the patients, the people who this is for, if the content of the questions reflects their lived experience, their reality, right? So I don't know if, I think that will be a fun part. I mean, I didn't think about peanut butter, but I think that will be the fun part of redesigning this tool, but I don't know. It's not that simple.
No, I'm sure it's not. So how many different investigators do you want to have tests once you've got the tool of, structured the way that you want that to ensure that you've got the internal validity?
Oh, you're asking me one of those PhD kind of questions, and I don't know that. I'm going to need a lot of help with probably the bird clinic. I need people who understand numbers to help with this and understand psychometric properties or the measurement properties and what is required for strength and analysis. I don't know. The real answer is I don't know.
Thank you.
I have a question along the lines of what you're doing. So, my wife is an ESL teacher of English second language, and so you have a lot of health disparities. I'm not sure about, I don't know the background with your CVI or the other, but and then different language characteristics even within. So when you do this, how do you make it, if you're making, and I guess there's a pediatric population involved possibly, or so is there also a consideration of the different groups, how they would read these questions? Because when you take this from Europe and maybe, I don't know, just guessing, maybe slightly more homogeneous, would you have to do some regional adaptation, or even, I can see within regions of the Mid-South, we have very different populations.
Yeah, that might be something that we'd have to consider. We've been in touch with two researchers who have, one in India and one in France, who've published about the scientific guidelines and criteria for performing cross-cultural adaptations of outcome measures. Because what's interesting about this Flemish CVI questionnaire is that it was published in English and was translated. So I have the translated version to English. I asked the author, who is a pediatric neurologist in Belgium, I asked the author, who was gracious enough to email back to me, but she said, no, she translated it just for the purposes of publication to an international audience. So we don't have any evidence for the process of translation, but we know now that there are a lot of instruments that have been translated and are used in other cultures, but sometimes you can't just translate something because it doesn't always translate. It's not just a matter of linguistic translation. There's the cultural piece as well, which is why it's called the cross-cultural adaptation. I'm going to learn a lot during this process if we get it off the ground.
It sounds really important to get that adaptation. I think it sounds like it would have an impact on what you're actually, how it would be interpreted, right? But
yes.
I had just another question. When you were doing the systematic review and going through, and I can't remember all of the classifications, but the rigorous studies or the ratings of the study, just out of curiosity, you find that the more usable studies and more rigorous studies were in the better journals, or was there any relationship to where it was published, or was it all over? I was just curious.
I never looked at where it was published. I don't know.
Sometimes
I can go back and look at
a better journal might have a better study, but I was curious if that really works.
I didn't consider that at all.
Okay.
I mean, that would be a whole other level of of interpretation. We were just really interested in
Mm.
those three questions, like what can an OT use? Is it like, what are the measurement properties, and what is it like to use in the clinic? So there were a lot of questionnaires, for example, well, both questionnaires and performance-based. One of the performance-based tests was real simple. It had playing cards, and a deck of cards, and the child had to match cards, and then it was timed. But the issue was that you did it in the clinic, then you had to do it in a classroom environment, so a noisy, distracted environment, and then come back and do it back in the clinic. So you had to do it 3 different times in 3 different environments, record each one. So it was really more of a research assessment. It wasn't feasible to use in the clinic. One of the and then there was something very similar with one of the questionnaires, which asked about the child, so the parent would respond, but it was in typical illumination, like in a, in the office that I'm sitting with standard illumination, and then in a darkened environment. And again, like same questions, but having to do it in 2 different environments it's questionable whether the child is doing the same stuff under dark conditions and under light conditions. Probably not.
We have time for additional questions. Any of our doctoral students?
Yeah, I had a question just based off of kind of what you were just talking about with the feasibility. I remember one of your slides, one of the tests had like 98 questions, and it was almost like, okay, it's unfeasible because it's going to take so long to take. But then how do you determine what the threshold is for the number of questions that are required? Like where 5 questions versus 98, how do you choose, I guess?
Yeah, I mean, I don't know. I'm just looking at it from a clinical point of view. Like, okay, here you've developed an assessment tool, and you're telling me, here, use it in the clinic. So I'm using it in the clinic, and I was reporting back on what is my clinical experience like. I've got a child who I have to try and encourage to keep looking. This is a child with vision difficulties, and now I've got to try and keep encouraging them to look, and it's very difficult for them. So I think it's really important to test. There's a difference between research and clinical. And that's what I was seeing in the systematic review, was that there's some in that case, with that assessment, it's very comprehensive, it's great, but it's not very feasible.
Yeah. I've seen that kind of coming from the public health background, and I think it kind of plays here with the sort of implementation science. How do you take some of these things and what can actually be implemented? We see those difficulties too when we're trying to collaborate with clinical partners, and then the measurements they can take on patients that are clinically feasible that we can actually use, they're often not compatible. So it's a really important question.
Yeah.
That whole implementation science area is a big area too. Actually, that's sounds like some of the things we're actually talking about.
So I guess I have a follow-up question on that too. How would you best or most efficiently promote communication between clinicians and researchers?
That's really good. I think maybe one of the things that needs to be done is that maybe clinicians need to be part of the research team and need to be test driving the products.
Mm-hmm.
Right.
And reporting back. And I'm not sure what you call that. What kind of outcome measure, what do you call that? And how do you report that? But I think that needs to be done too.
Yeah. Well, that's the whole concept of team science. People pushing, but it's hard to get it all going. Do we have any other last questions?
Well, I just wanted to weigh in. I agree with Orly that it's very much a question in the clinic of not only can you get an outcome measure that's meaningful and relevant in it or 15-minute window while you have the attention of the client, while you
Yes.
have the clinical time for your assessment to occur. And maybe as researchers going and trying to get back into the clinic, we might need to take that into account in building our models. That we look at building shorter assessments with stronger outcomes.
Very good. All right. Well, I would just like to thank you again, Orly, just for a very thought-provoking presentation, and good luck on this project. And I hope we can help you as you try to move it forward.
Thank you so much.
Thank you for attending, and we'll tell others we'll have this recorded, and hopefully everybody will have access. Thank you.
Thank you so much.